Hi everyone, thank you for joining us for today's webinar. My name is Morgan Gargiulo from the New England QIN-QIO, and I'll be moderating today's session. Get to the front of the pack. Pick your pace for MIPS. In case you didn't know, the New England QIN-QIO works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Before we get started with today's webinar, I wanted to review a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. As I mentioned, you should have heard the automated commands come through. The phone lines are on mute for the duration of the presentation, and we will be taking questions at the end, and we will instruct you on how to unmute your lines at that time. Throughout the presentation, if you have any questions, you can always add them into the chat box in the bottom right corner of your screen. So with all that said, I will now pass things over to Rachel to get us started. And Rachel, just make sure you press #6 to unmute yourself.
Hi, thank you, Morgan. Can you hear me okay?
Yes, we can.
Okay, great. All right, thank you, Morgan, and thank you to everyone for participating in our webinar. Today we're going to focus on the different reporting paces and data submission methods for the 2017 transition year for MIPS. As we enter into the final quarter of this calendar year, it will be important to have a plan in place, and we hope that this webinar will be helpful. Today is a relevant date on the 2017 transition year timeline, as it's October 2nd, which marks the last start date for a 90-day reporting period. We're going to go into that in a little more detail once we get into the different cases that you can pick for your reporting. And as Morgan said, we will have time at the end for Q&A, but feel free to enter questions into the chat as they come up, and we'll either address them throughout the presentation or at the end. Okay, so this is just a disclaimer. We are CMS contractors, and we created this webinar for educational purposes. It's not meant to replace any of the rules and regulations around the final rule related to MACRA. And this is our plan for the day. We're just going to, or for this hour, I should say. I'm going to give a high-level overview of what MACRA is. We'll talk about eligible clinicians, the various MIPS reporting paces, and then I'm going to turn it over to Leila Valinsky, and she's going to talk about data submission methods, resources, and then we'll do the Q&A. So as everybody probably knows, that CMS loves acronyms, and with this new legislation has come a large number of additional acronyms. So here's a list of some. On our website, we do have a document that you can use as a resource with even more acronyms that are relevant to the Quality Payment Program and MACRA. But a few that are going to be said throughout this presentation would be APMs, which are Alternative Payment Models, MACRA, which is the Medicare Access and CHIP Reauthorization Act, MIPS, which is the Merit-Based Incentive Payment System, IA, which is Improvement Activities. We'll refer to QPP, which is the Quality Payment Program. If you hear us say EC, that means Eligible Clinician, and then ACI is Advancing Care Information. Okay, so what is MACRA? MACRA is legislation that repealed the flawed sustainable growth rate, and that was put into act in 2015. The final rule came into play in October of 2016 for the performance year of 2017. They're currently in the process of finalizing the rule for the performance year of 2018, but we won't go into detail on that within this webinar. So with MACRA, there was strong bipartisan support, so we don't anticipate that this is going to go away with any changes in the administration. It's not part of the Affordable Care Act. That's come up a lot of times. People say, why should we participate? It's probably just going to go away, but we don't anticipate that happening anytime soon. So essentially, MACRA created the Quality Payment Program, which includes two different tracks. So there's MIPS, the Merit-Based Incentive Payment System, and APMs, which are alternative payment models. With MIPS, you can participate and receive a positive payment adjustment based on your performance. So essentially, let me backstep. The quality payment program is starting to shift from volume-based payment to more of a value-based payment system. So essentially, that would be why you can get a positive payment adjustment based on your performance. So higher performers can get up to a 4% payment adjustment in the 2017 transition year. And those that don't participate will automatically receive a 4% negative payment adjustment on their Part B claims. We'll talk about how you can avoid this negative payment adjustment in the next couple of slides. And then there's also alternative payment models. So within alternative payment models, you can receive a positive payment adjustment based on your performance of up to 5%. And it follows, in order to be an advanced alternative payment model, you have to follow a risk-sharing structure that includes both upside and downside risk. You can be part of an alternative payment model called a MIPS APM that does not follow the both upside and downside risk. It only is upside. So they have a special scoring standard called the APM scoring standard. So it's favorable MIPS scoring, but we won't get into too much detail about that. So this is just a visual of what the quality payment program is and the two different tracks. So essentially MIPS streamlines 3 previous CMS reporting programs or the quality payment program streamlines 3 previous CMS reporting programs into MIPS. So you have PQRS, which translates into the performance category of quality within MIPS. Meaningful use translates into advancing care information. And then the value-based modifier is also known as the cost category. MIPS also has a 4th performance category called improvement activities, which is a new category. And those 4 categories, quality, advancing care information, cost, and improvement activities, come together as MIPS, and you get scored, and there's a final MIPS composite score, and your payment adjustment will be based on all 4 of those categories. However, for this year, cost is not factored into that final score. Again, so APMs are the alternative payment models, and you have the MIPS APM. So, for example, the Medicare Shared Savings Track 1, there's no downside risk, and the majority of the ACOs in the country are the Track 1 ACOs. And those that have the both upside and downside risk could qualify as the advanced APMs, and we just listed a couple of the more common advanced APMs that you may be part of. So why should clinicians be concerned about MIPS? There are obviously a financial impact. This year, it's 4% is the maximum negative payment adjustment or the maximum positive payment adjustment that you can receive based on the 2017 performance year, and you'll see those adjustments in 2019. But over the next few years, those adjustments are going to increase. So by the time we reach 2020, you can be seeing a 9% negative adjustment based on your performance. So you really want to start getting a plan in place and start thinking about this program prior to when the maximum adjustments start increasing and it starts having more of a financial impact. And again, the adjustments are on Medicare Part B payments. So eligibility and exclusion criteria. So who are eligible clinicians? So this includes physician assistants, or physician assistants. So we're including MDs, DOs, chiropractors, doctors of optometry. Then there's also nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. We anticipate in the next few years they'll be adding clinician types. But for 2017, these are the clinicians that are considered eligible clinicians. You can be excluded from MIPS if you fall below the low volume threshold, which means that you're an individual clinician that doesn't submit more than $30,000 in Medicare Part D charges per year, or you provide care for fewer than 100 Medicare Part B patients a year. So if you fall below the low volume threshold, then you can be excluded from MIPS. CMS has a website, the QPP website, where you can put in your individual provider NPI number and see if you're included or excluded based on that individual status. Also, if you're newly enrolled in Medicare for 2017, you're automatically excluded and you won't see any positive or negative payment adjustment. Or if you're significantly participating in an advanced alternative payment model. So if you're one of those models that have two-sided risk sharing, so Track 2, Track 3 shared savings program, or the other programs that were listed on the previous slide, you're excluded from MIPS because you're already participating in a different track within the quality payment program. So we've been referring to 2017 as a transition year for MIPS. So essentially, CMS doesn't want all clinicians to be too overwhelmed. They know that this program, there's a lot of detail to it. It's a big change, and they want clinicians to succeed, and they don't want everybody to be receiving these negative payment adjustments. So they've created this transition year, which essentially is to ease the burden of participation and to help clinicians kind of ease their way in and learn the program without being negatively impacted right from the start. So they've created these pick-your-pace reporting options, which we're going to go in-depth in just a minute. But essentially, you don't have to participate in MIPS as fully as what had been stated in, or what might be in the upcoming years, excuse me. And so rather than having to submit data on every single category, you can pick and choose, I only want to submit data in one category, or you can participate more fully. But essentially it provides a path to easily avoid a negative payment adjustment. And as you can see on the pie chart, we have the 3 different performance categories that are going to come into play with your final MIPS composite score for 2017. We do anticipate that these weightings will change eventually down the line, but for 2017, quality is at 60%, advancing care information is at 25%, improvement activities are at 15%, and as I mentioned before, the cost category is not having any weight in the final MIPS composite score for 2017. So what is pick-your-pace reporting? So this, again, enables eligible clinicians to have flexibility in the reporting that they're doing while testing and learning out the program. You can customize it to what best fits your practice. You can submit as little data as you want or as much data as you want in order to avoid a penalty or earn a positive payment adjustment. So we have the 3 different paces, which would be the crawl pace, the walk pace, and the run pace. Crawling, you're just trying to avoid that negative penalty, and you're going to submit less than a 90-day period. The walk category, you have the potential to earn a small incentive, and you'll be submitting more data in each of the different MIPS categories in order to potentially earn a small incentive. And then run, you're fully participating in the program. And we're going to talk about those categories right now. Okay, so MIPS Pick Your Pace Crawl. Again, this is strictly to avoid a negative penalty. Like I mentioned, CMS is trying to make it very easy for clinicians to avoid that penalty. So essentially, you can choose one performance category for your reporting. You don't have to report data in each of these 3 categories. You can focus just on quality, just on improvement activities, or just on advanced care information. And so for the quality category, the requirement would be to report on at least 1 quality measure with at least 1 patient in the numerator. So essentially this is where you can report on 1 patient at 1 point in time. We don't recommend just reporting on 1 patient at 1 period of time. we recommend a sample of at least 20 patients in case for some reason that one particular patient gets excluded from the quality measure that you chose, and then that would leave you with no data that is relevant and getting a negative adjustment. So we recommend choosing at least a sample of 20 patients to help cover yourself in case there are some patients that were excluded for that particular measure. But essentially, that's all you would have to do for the quality category to prevent yourself from getting a negative payment adjustment in 2019. And you can select any time during the reporting, during the 2017 performance period. It doesn't have to be a specific time frame. As long as it happened during 2017, you're good. And again, no minimum reporting requirement. So improvement activities. This is a little different because you have to use at least a minimum 90-day reporting period. That's because when you're implementing an improvement activity, they want to see that you're working towards that specific activity. So there is a 90-day requirement for improvement activities. But essentially, there's over 90 improvement activities to consider, and chances are you can find an improvement activity that you are doing within your practice or that you've been interested in doing. There's a lot to choose from. So this could potentially be a great category to choose if you just want to test the program out and kind of just avoid that negative adjustment. So you can choose one improvement activity in order to avoid that payment adjustment and attest to that. And then the third category that you have the option of reporting on is advancing care information, which again is formally meaningful use. And in order to fulfill this category at the minimum amount of reporting, you would have to attest to the required base measures. So for 2014 certified EHR technology, there's 4 base measures, and for 2015, there's 5 base measures. You can find information on these different measures and essentially measures throughout all these categories on the QPP website, or you can contact us. But essentially, you would just have to attest to those required base measures and advancing care information to fulfill this category. And it does also have a minimum 90-day reporting period, and you must have CERT. And again, I just wanted to mention, so today is October 2nd, so today marks the last start date for a 90-day reporting period. So from now until the end of the year, we have 90 days left until the performance year is up. So if you're going to be implementing an improvement activity, it's something that you probably want to work on getting in place. Advancing care information, if you're going to be trying to fulfill these base measures, the minimum reporting period starts today. So that's the crawl pace, and if you choose one of these categories, you can avoid a penalty. So then we have the walk pace. So the walk pace, you're avoiding a downward payment adjustment, and you have the potential to earn a positive adjustment. So this pace, you would submit data for each of the performance categories for at least a 90-day period. So this is testing out the program a little bit more thoroughly. So you're looking at all 3 categories and submitting data on all 3 categories. And so for quality, you want to report on 6 quality measures, with at least 1 being an outcome or a high priority measure. And you would be doing this for a 90-day period. And so with the quality category, the minimum requirement is 6. You can always submit more measures, and CMS will score more measures. But again, you would have to make sure you're submitting on at least 6 quality measures to fulfill the requirements. And improvement activities, this category is the same as it is for the crawl pace. You would implement an improvement activity. However, based on your practice size and based on the weight of the improvement activity, you may have to implement more than one. So essentially, the improvement activities have a different weighting based on which activity it is. So you have high weight and medium weight activities. For small practices, You may only have to implement one high weight activity. For larger practices, you can implement 2 high weight activities or 4 smaller medium weight activities. But again, this would be for a 90-day reporting period, and there are many, many activities to choose from. And then advancing care information, again, same as the crawl paste, you're going to be submitting data for a 90-day period. You're going to attest to the required base measures, and you have to have either 2014 or 2015 cert. And so once you put all of these 3 categories together, you're going to be earning more points towards that final MIPS composite score. So hopefully you're able to earn a smaller incentive. And then we have the run pace. So this pace may be for those that have participated in PQRS, have participated in meaningful use, and are really comfortable with data reporting in these quality programs. You might want to try to submit for a full calendar year, because we do anticipate in upcoming years that eventually the requirements will be to submit data for a full calendar year. Again, we're in the transition year, and that's why they're allowing for these 90-day periods, because they want to have people participate and learn the program. But again, if you have the capabilities of submitting data for a full calendar year, this will give you the opportunity to earn more points towards that final MIPS composite score and help you achieve that maximum incentive, positive payment incentive. And also, if you are a high performer, you can fall into a pool of high performing clinicians and get a high performer bonus. So by submitting calendar data for a full calendar year, you have more opportunity to reach that high performer bonus. So the quality category, you would have to report on at least 6 quality measures again for the full calendar year, and then consider reporting on additional measures for bonus points. And as I had mentioned before, you can submit for more measures and allow CMS to score them so they can kind of see, they'll pick the measures that you score the highest in. So if you have the capability of submitting some more measures, you might want to do that. Improvement activities, it's the same as the walk pace. You would, the maximum number of points you can earn in the improvement activities category is 40, so you would want to pick and choose a combination of improvement activities that would get you to that full 40 points. And with the improvement activities, they're always a 90-day reporting period, so you don't have to attest that you've been doing improvement activities for a full calendar year. It's just attesting to a 90-day period. And then with advancing care information, this category, you would want to attest to the required base measures for a full calendar year, but then you would want to look at some additional measures that they have available. So there's performance measures, and then there's bonus measures. So essentially, the more measures that you're reporting on, the more points for advancing care information that you can get. So you would want to look at all of these measures and submit data for additional measures aside from just those base measures. And together, this should give you more opportunity to earn a higher final MIPS composite score. So the next 2 slides is just kind of a snapshot of a pick-your-pace reporting table that we've developed through our QIO. So I didn't mention this first pace option because it's do nothing, and we don't recommend you do nothing. Like I mentioned, CMS is making it as easy as possible to avoid that negative payment adjustment. So it would be silly to do nothing and get that adjustment when you really don't have to do a whole lot to avoid it. You can contact us and we can figure something out and make a plan if you're having trouble, but that shouldn't really be much of an option. And then, again, summarizing this table summarizes the crawl category. The next slide shows the walk and the run category, and it also shows the total performance points that you would be shooting for with each of these categories. So we have this document available on our website, which will be on the resource slide at the end of the presentation. But it puts it nicely into a table where you can see what the performance requirements are. So now that I've talked about the pick your pace reporting, I'm going to hand it over to Leila Valinsky, and she's going to finish up the presentation with data submission methods. So,
Great.
Leila,
Thank you, Rachel.
you're welcome. Let me pass you the ball.
Hello, everyone. Thank you for joining us today. As Rachel mentioned, there's lots of different case reporting options under this transition year of MIPS, which hopefully allows for that flexibility that Steve mentioned, where CMS is really allowing clinicians and practices the opportunity to test out the program, see what works best for them. If they're in the process of transitioning from one EHR vendor to another, maybe it makes sense to do that test or the crawl pace, as we like to call it, just to do the bare minimum, and then next year shoot for more full participation. But lots of options. I have a couple slides before I go on that have screenshots of either an EHR vendor or the old CMS portal. I just want to let you guys know those are just to show you what they look like. We do not support any EHR vendor. We're vendor neutral. It's just to give you an idea of what it would look like. And the CMS portal is not yet available. If you are planning to report via claims, this is an option only available for individuals, and it is only available for the quality category. You can't submit any other data via claims, and you cannot submit data as a group. So this is the CMS Claims 1500 form. As you can see with the arrow at the bottom, that field, which is very hard to see, I apologize, it's a small picture, is where you would enter the appropriate CPT or HCPCS code based on the patient population of whatever measure you select or measures that you select to denote what population that patient falls into. Is it the numerator population or the denominator, or are they excluded? So important element if you're planning on reporting via claims. As I mentioned, claims is only available for individuals. With claims, it's a little different than if you choose any of the other reporting methods. You actually submit data pretty much to CMS throughout the year. So, as Rachel had mentioned, today, October 2nd, is the last day to start a 90-day reporting period. If you chose to report claims, you could actually start reporting data earlier in the year. So you could be submitting data to CMS, obviously, starting January 1st for this performance year. But you have to make sure, again, that you have that appropriate CPT or HCPCS code on your claim, because that's how CMS identifies where your patient fall. They won't automatically enter that code if the patient, let's say, had a hemoglobin A1C, they're diabetic, and it's over 9. They wouldn't add that value to your claim to show that patient's in the numerator population of that measure. You would have to make sure that's included when you submit it to CMS. Just to give you an idea of what the claims, the various CPT or HCPCS codes that I mentioned. So this is the A1C measure I just mentioned. So as you can see here, the numerator population, there is an exclusion for this measure. So patients in hospice services, you would need to enter that G9687 code. If the patient had a hemoglobin A1C performed during the reporting period and the value is greater than 9%, you would enter the CPT code of 3046F. And then if that A1C wasn't performed for whatever reason, that patient, this is an inverse measure, so you actually lose some points there. They would get that same CPT 3046F with an 8P modifier. So it's really important to understand and have someone who understands billing be able to help you with this, because you might not know exactly where to enter your codes. And then again, if you had a patient who had an A1C performed, but they're within two different, below that 9% population, you might enter either the 3044F or 3045F code. This is a link to the quality measure specification sheet. Again, this is a claims-based measure, so you want to make sure you're selecting claims-based specification sheet. Moving on, again, this is just a sample screenshot of an EHR vendor. We do not support one vendor over another. Many EHRs have MIPS or other quality reporting dashboards. This is just to give you an idea of how you're performing. So protect patient health information, that's that security risk analysis. That's a required. There's no patient populations for that one. So you could just click complete in this example. E-prescribing shows that this provider has 1 of 42 patients, so at this point they would be excluded from that measure. Provide electronic health access, that's the portal. There's 2 of 2, they're 100%. And this vendor isn't currently able to show the health information exchange percentage. But just to give you an idea, talk to your vendors. They have lots of different options available. And also, be sure to talk to your vendor about whether or not they can support EHR direct reporting. Not all vendors, even the large ones, are able to submit your data via EHR direct. Sometimes they have a separate data submission vendor that they might use, and sometimes this just isn't an option. The other element to consider when thinking about using your EHR is what quality measures are you planning on reporting on? Because usually EHR vendors certify about 60 to 100 measures. So it's really important to know, is that measure that you're planning on reporting on certified by your vendor? If not, you might not have a mechanism to report it using your vendor and might have to go either the claims route or through a registry. So really important to know what elements you're considering and if they're supported. Again, this is kind of small and I apologize. This is a ECQM, which is the Electronic Clinical Quality Measures specification sheet. Those can be found via this link. And if you click on this link, you want to go to the EC/EP measures. If you scroll down, you have to click a couple buttons. If you scroll down, there's this data criteria towards the bottom. As I mentioned with the claims-based measure, wanting to make sure you have the appropriate CPT codes. These measures have very specific sets of diagnosis codes, so those are those ICD-10 codes, encounter codes, so those are the evaluation and management codes. You really need to make sure that you're using the appropriate code to pull your patients into that specific measure population. So looking at this, you can go to this. This is a very long number, those 2.16.84. I can't even read it myself. But that links up to a set of data that would show you what the appropriate ICD-10 codes are. Again, if your vendor can support it, they usually have all of that data and can help make sure that you are identifying the appropriate patient population. I want to talk about registries and qualified clinical data registries, or QCDRs. So if you select registries, there's a couple different options you can pick. Some registries are specific to a specialty association. So the example I have right at the top of the screen is the American College of Surgeons. The one right below it, however, though, is the American Health Information Technologies, LLC registry. They're offered by all different organizations, and they have very different capabilities. So in the first example, the first box you'll see under that performance category supported, the first option, that American College of Surgeons registry, can only support reporting to the improvement activities category and quality. However, the American Health Information Technologies registry can report to all categories, advancing care information, improvement activities, and quality. So important to know where you're planning on reporting data and how you want to submit that to CMS. The next column over is the quality measures supported. As you can see, the American College of Surgeons only has about 15 measures that they have available, whereas the second has all registry eligible quality measures. If you look on the quality measure page, I apologize, we don't have a screenshot of it. Each quality measure shows what the data submission method is supported. So if you look, let's say you pick the diabetes A1C, that's supported by all data submission methods. So you'll see right there that you can submit data via claims, EHR, registry, and if you're not a large group, the CMS web interface. So important to look at that and see, can I submit this measure via the method that I want to use? They also support all electronic clinical quality measures. To get to a list of CMS approved qualified registries, you can click this hyperlink at the bottom. I'm just going to tell you now, it's a very large PDF document that's somewhat tricky to search through, but they are all listed there if you're interested. Qualified clinical data registries, much like regular registries, typically go off of that specialty association. So my example here is the American Academy of Allergy, Asthma, and Immunology. Much like my previous example, this table shows you the performance categories that are supported. So this registry can support advancing care information, improvement activities and quality. Again, roughly 15 MIPS quality measures. However, with QCDRs, unlike qualified registries, you do have the option to also report on and have counted non-MIPS measures. So those are those QCDR measures. And here you can see for asthma, there's the assessment of asthma control in the ambulatory care setting, and I have a couple others listed. So really important, again, to determine what makes the most sense for your practice, what measures are you selecting, what makes sense for your patient population, and so on. There's a separate document for the approved qualified clinical data registries, and you can access that via that link. Much like the claims-based reporting, the specification sheet looks very similar. So you can see here the numerator. I forget what measure I did selected for this, but it tells you a little definition of the lower extremity neurological exam, and then different patient populations. So if the performance is met, you could use the G8404 code, or you could just make sure that this documentation resides in your electronic health records somewhere. Registries and QCDRs oftentimes allow for both manual upload of data as well as a direct interface right into your EHR. So a couple different options to consider. Again, here's the link to the specification sheet. For this one, you would want to make sure you select registry measures. As I mentioned, if you're using a registry or QCDR, you may be able to submit data now. Some registries are allowing you to, again, upload that data or have your interface pull the data right out of your EHR. Make sure those measures are certified by your registry and available. And if you're planning on using that registry, as I mentioned, make sure you can support all of the performance categories. Or if you're planning on submitting data a different way, that the method that you want is available. So attestation is available only for the advancing care information and improvement activities category. CMS will be making a portal available. You can use this for both groups and individual data submission. The portal, as I mentioned already, is not yet available. It'll likely be December, end of the year. It has to be made available no later than January 1st because that is when data submission begins. For those of you familiar with the Meaningful Use data submission portal, attestation portal, I apologize. This is a screenshot from that former portal. I'm assuming, but I can't make any guarantees, that this new MIPS portal will be very similar to the Meaningful Use portal. But again, we didn't really know. CMS hasn't released any additional information, but it will be some sort of form where you'll enter what measures, the numerator denominator populations, or any exclusions you have. If you are in a large group of 25 or more eligible clinicians, or are part of an an alternative payment model, getting tongue tied today, you will be reporting at least your quality information using the CMS web interface. This web interface is kind of a similar portal, but a little different. It pulls specific handfuls of patients identified by CMS, and you'll be reporting on 15 predetermined clinical quality measures for a full calendar year. If you are, again, in a large group, you can choose to attest for the advancing care information category and improvement activities if it's appropriate. Again, that's for at least 90 days. You must, if you're in a group of greater than 25, have registered with CMS to use those CMS web interface by June 30th. So if you haven't yet, you will not be able to use it for this year, but you can plan to use it next year. Again, you report on a consecutive 248 patients for a predetermined set that comes from CMS. So be on the lookout for that. You should receive that towards the end of the year if you're using this method. Much like the other data submission methods, there are specification sheets on how you can determine what patient populations your patient should fall into and if they've met the requirements. Here's just an example of the influenza immunization numerator reporting. So again, it's denominator exclusion, so you can work through this and say, oh, okay, I had a patient who received the influenza immunization prior to the timeline, so they would fall out for this year. With that, we'll open it up for questions. Actually, I think I have resources. Sorry, I jumped the gun. We have the New England QIN-QIO's website, which is neqpp.org. You can also ask us a question directly on that website if you would like. There's also a link to the CMS Quality Payment Program website, which is a great resource if you have additional questions. And both my information and Rachel's information is at the end of the slide. I see a couple questions in chat. Rachel, do you want to jump in, or you want me to take a couple?
I'll let you take a couple. I know there was one on claims-based reporting. So we can't use claims to report as a group, but we bill as a group. So essentially with claims-based reporting, you're submitting those claims through each individual provider. So there is no option to report claims as a group. I don't know if you want to add anything to that, Leela.
No, I would just say I'm not sure exactly how you have it structured to bill as a group because it does usually go with that specific encounter with that clinician. So that's how the clinicians would have to report. Next question, let's see. And if EHR is carrying the numerator denominator, then we do not need claims. I'm not sure I completely understand that question, but if you're reporting through your EHR, then no, you would not need to use claims.
So the next question was in regards to FQHCs that participate in ACO Track 1. I answered that question, just with a little bit of detail in the chat box. So essentially, if you're part of a Track 1 Medicare Shared Savings program, things work a little bit differently than what we just went through. The presentation we just went through was basically for traditional MIPS reporting. For Track 1 ACO, you are part of a MIPS APM, so you fall within that special APM scoring standard. So the quality category, which is what you were asking about, that you should already be submitting data to your ACO on quality, and they should submit that data on your behalf. So you're going to want to talk with your ACO about what they're doing for MIPS and just make sure you have everything in place and what clinicians within your QIN are participants of the ACO, because they have to be participants of the ACO in order to get that special scoring.
Great. Next question was, can we report performance or bonus measures for the ACI category if we choose the walk pace? Yeah, absolutely. The walk pace, you can perform really as many measures. You can use the 6 quality measures or fewer. You can report on as much of the advancing care information category as you want. It's really just your performance. So as Rachel had mentioned, how you perform on the various measures. If you can earn between 4 and 69 performance points, that's where that walk pace comes in. And typically you get to that point by reporting on about 90 days of data. Sometimes you can get exceptional performance within 90 days, but oftentimes you're kind of right in that middle bracket. Oops, sorry, I just bumped my cursor down. Now I can't find where I was in the questions. Oh, there we go. Question was, for e-prescribe, is this a straight on-station that we check the formulary? No, this is sending prescriptions electronically. So that could include checking your formulary, but the prescriptions must be sent electronically, not paper, not fax, but electronic.
And this is a numerator and denominator measure.
Yeah. If you are a medical home, does that cover the improvement activity? You would have to be recognized as a patient-centered medical home. So if you have already been recognized by NCQA or a different recognition body, yes, that would, but I would make sure that that body is authorized, because sometimes there was a little confusion early on with the program that some of the medical home models were not acceptable, so just check to be sure if they're covered. Where does one find the G code? That's a great question. So if you go onto the QPP website, there are 3, I'm going to call them tabs. They're not really tabs at the top. One says MIPS, one says APMs, one says About. If you click on About, and then you'll see Resource Library. Click on Resource Library, and then if you scroll, it's pretty much all the way to the bottom of the page. You'll see Quality Measure Specification Sheet, or Specifications. If you click on that, it's a zip file. Open that, and that's where you find the quality measure, either registry or claims-based measures, and the specific algorithms to identify G code or CPT code or HCPCS code that you need to report. No, it is not mandatory to implement chronic care management, and that's just a bonus you can get. Chronic care management actually isn't really included in MIPS at all. You could maybe lump it into one of the improvement activities, but it's an additional way to bring in some revenue to your practice outside of MIPS. Great question someone asked. Can you explain the difference between group and individual reporting? So individual, obviously that's a solo clinician reporting their data on their own. They could be part of a group, but they are submitting their data as a single clinician. So they can pick whatever method they want. You have the option to select different data submission methods for each different category, but within a category you have to submit one single method. Groups, really it's at least 2 NPIs coming together. The difference between groups and individuals is, let's say you're in a group of 5 clinicians. 2 of those clinicians meet that low volume threshold that Rachel had mentioned. 3 do not. Groups have the same low volume threshold as individuals. So as a group, you have to meet that $30,000 in Medicare Part B claims annually and 100 Medicare beneficiaries annually. Obviously, usually as a group, that's much easier to meet because you have multiple clinicians applying claims and patients to the aggregate score for that number. So as a group, all of the clinicians, eligible clinicians within that practice, aggregate their data for the various measures that are selected, but otherwise it's the same principle. You would select 1 to 6 quality measures. You could report tests if your group was struggling. You really can report however you want. If you report as a group, though, you are measured as a group across all of the performance categories. Rachel, anything you want to add to that?
No, I think you covered it pretty well.
Let's see. Are the improvement activities a yes or no? Yes, they're attestation only. So yes or no. But to have documentation. That's the biggest piece. You want to take the next couple, Rachel?
So for transitions of care, providers exempt if they have less than 100 referrals. So I'm assuming, is this for the advancing care information category for the health information exchange? And Leela, they are exempt, are they not, for that measure?
It's in the proposed rule that they'll be exempt. I would be shocked if it didn't get finalized, but it is only a proposal at the moment, so just be cautious of that.
Okay. All right. So the doctor I work for will be retiring in February of 2018. Would this exclude us for 2017? So essentially 2017 is a performance year, and based on your performance in 2017, there'll be payment adjustments for 2019. So if this clinician is retiring in 2018, then essentially he wouldn't have any claims. He wouldn't be submitting any claims for 2019. So I would just make sure that he is the solo clinician in this practice and that he actually is planning on retiring, but essentially if he's not going to be submitting any Part B claims in 2019, then you wouldn't really have to worry about it. Okay, so for maximum credit, do you need to surpass the benchmarks? So for the quality category, there are benchmarks for a large number of the quality measures. Not all measures have a benchmark. So for this year, submitting any data for a measure will get you at least 3 points. In order to receive maximum credit for a particular measure, you would want to look at the benchmarks, and within the benchmarks, there's what they call different deciles. So you could earn different amounts of points based on your performance. So if you go to the QPP website, there is a file or a spreadsheet that goes through all of the quality measures and their benchmarks, and you can estimate the amount of points that you would receive for each of these quality measures. So the higher performers will obviously get more points for each measure. Okay, let's see. For e-prescribing, are providers excluded if they prescribe less than 100 prescriptions? Yes, if they prescribe less than 100 prescriptions, they would be excluded from that particular measure within advancing care information. And like the quality measures, there are measure specifications on the QPP website. And you can download the measure specifications for the advancing care information measures. They're in a zip file as well. So if you download that e-prescribe measure, it does reference this exclusion. Can you clarify that the negative or positive incentive applies only to Part B reimbursements for the FQHC practice? The transcription earlier said Part D. Okay, so the negative or positive incentive does only apply to Part B reimbursements, and that's for everybody that's participating. So as we know, FQHCs have limited numbers of Part B claims, so they might not be affected financially as much, but depending on how they are participating, if they are required to participate within a Track 1 ACO, they will see whatever positive or negative adjustment is given to the group as a whole on the Part B charges that they do file. And it is strictly Part B.
And if we have anyone on the phone, you're more than... Oh, sorry, go ahead.
No, I was just going to say, did you have anything to add to any of those questions?
Yeah, no, that was great. And yeah, I apologize if the transcription, that pulls off of what we're saying. So B and D obviously sound very similar, so sometimes it's an electronic transcription, so they get a little confused with some words and letters that sound similar. If anyone has questions on the phone, you can press #6 and ask your question over the phone. We have a few more minutes, so lines are open if you have any additional questions.
While you guys are thinking of any more questions, I did want to give a few announcements. As you close out of the webinar, the evaluation will automatically pop up on your screen. If you could fill that out, we would greatly appreciate it. If you don't have time to fill it out right now, or you're currently sharing a computer with someone, you will receive an email tomorrow morning that will contain a link to the evaluation. The email will also contain a link to the event page on our website, where you can find the presentation from today. And then within the next few business days, we'll also add a transcript and recording to that web page if you want to go back and review any of the things that were discussed today. So that's all I have. Again, as Lila mentioned, if you have questions, you can press #6 to unmute your line and ask a question.
So I do see that there is another comment. I thought providers and FQHCs were excluded from reporting in MIPS. So this does get a little tricky, and it kind of comes into play with group reporting. So FQHCs, essentially the clinicians within FQHCs are excluded from reporting in MIPS if they fall below the low volume threshold. So the exclusion isn't because they're part of an FQHC. It's because when you are part of an FQHC, you don't bill, you have limited Part B billing, if any. So the majority of clinicians in the FQHCs are excluded due to low volume threshold. However, if you are part of a MIPS APM, such as Medicare Shared Savings Track 1, they look at the whole...
The leader has disconnected. The conference will be terminated in 5 minutes.
So it gets really tricky. So we can explain this in more detail if you wanted to email one of us. But essentially, if an FQHC is part of a MIPS APM or Track 1 ACO, they're still required to participate in MIPS. But for some of the ACOs, just the data reporting requirements are a little bit different. So I'd be happy to talk to you in more depth if you wanted to email about this.
I'm so sorry about that, guys.
It's okay.
Hopefully you didn't hang up on everyone, and if we still have some questions, you guys can get them answered. I pushed the wrong button.
Are some of the measures for all patients, not just Medicare patients? Yeah, so essentially, for all of MIPS, all the quality categories, you're supposed to be reporting on all payers, not just Medicare patients, with the exception of claims-based reporting, because claims-based reporting, obviously, you're directly reporting your measures through the claims that you're putting through on Medicare patients.
And one more piece of that is there is a data completeness component to all of this, which we didn't mention. So if you report on the test pace or that crawl pace, or if you're doing just the bare minimum, data completeness doesn't really factor into the equation because you're just reporting on the bare minimum amount of data. Now, if you're going for a more substantial performance and thus more substantial participation, as you report on more measures, you are expected to report on at least 50% of your patients that are eligible for that measure. So as Rachel mentioned, outside of claims, that would be all patients, all payers. Within EHRs, oftentimes you can't designate it. Well, you could, but it'd be a lot of work to say this patient has Medicare, so we're only going to report on this group of patients. It really should be across the board. CMS is looking for higher quality of care just in general. But again, if you're doing claims, that would only be on Medicare patients, since those claims are only being submitted to CMS for those Medicare patients. Any last questions? We have 2 minutes. Great. Well, thank you, everyone, for joining. And as Rachel mentioned, if you have any questions, feel free to reach out to us. You can ask a question right on our website, or if you have our direct information, feel free to send us an email directly or give us a call. Thank you again. Have a great day.
Thank you, guys.